Hi everyone, welcome to the NSGC webinar, Introduction to Credentialing and Enrollment for Genetic Counselors, hosted by the Service Delivery Subcommittee of the Access and Service Delivery Committee. My name is Samantha Greenberg, Chair of the Service Delivery Subcommittee, and I'm pleased to introduce your speakers today, Kathy Matska and Cheryl Harper. Kathy Matska, CP, MSM, CPCS, FMSP, is a speaker, consultant, and writer with 30 years of experience in credentialing, privileging, and medical staff services. Ms. Matska worked for 13 years as a hospital medical staff coordinator before venturing out on her own as a consultant, writer, and speaker. She holds certification by the National Association Medical Staff Services, or NAMS, in both medical staff management and provider credentialing. She's one of the first recipients of the NAMS Fellow designation. This designation is the pinnacle of achievement and acknowledgement for the medical services professional, recognizing a career medical services professional who has made outstanding contributions to the profession through service as a leader, mentor, and educator. Cheryl is a genetic counselor with over 30 years clinical experience in prenatal, pediatric, and general genetics. In 2017, Cheryl transitioned to a laboratory position with Quest Diagnostics as a genomic science specialist and liaison, supporting the molecular laboratory in women's health. Cheryl has held many leadership positions within NSGC that include Chair of the Licensure and Payer Subcommittees of the Access and Service Delivery Committee, Chair of the Public Policy Committee, and Secretary-Treasurer on the Board of Directors. Cheryl started investigating the area of credentialing when it became necessary to determine how to bill for independent genetic counseling while she was providing clinical care in a pediatric and general genetics clinic. On this webinar, we'll be covering the following: institutional versus payer credentialing, the benefits and challenges of credentialing, basics, credentialing and privileges processes, the current state of credentialing and privileging for genetic counselors, and opportunities for further education. So I'll now hand it over to Kathy Matska to get started on an overview of credentialing.
Okay, we're going to talk about institutional versus payer credentialing, and it is different. It's performed differently depending on whether or not you are working in a hospital or you're applying at an HMO or a health plan in order to be able to see the patients of that health plan. So we're going to talk a little bit about both of them so that you can understand the differences in those credentialing and privileging processes. But first of all, why do healthcare providers and payers credential? Well, patient protection is the #1 reason. And of course, we're always going to want to have some kind of credentialing so that we can make sure that those people who are treating our patients are qualified and competent to perform the services that they want to do for those patients. And then there's also risk management concerns. Negligent credentialing is a real concern. And with negligent credentialing, if a provider injures a patient through an act of negligence and it's determined that the healthcare institution did not credential that person appropriately, then the healthcare institution can be held individually liable for those acts or omissions of that provider. Then there's also accreditation and regulatory compliance. Everything flows down from CMS, the Centers for Medicare and Medicaid Services, and they set accreditation and regulatory requirements that have to be met by hospitals and health plans if the health plans want to sell a Medicare Advantage program. So if they're not meeting those regulations, then they're not going to be able to participate in those plans. Also, each state has requirements about what kind of credentialing has to be done. So there's a lot of accreditation and regulatory issues that have to be looked at by both healthcare institutions and by managed care plans and health plans. So there's different accrediting agencies, and what the credentialing and privileging requirements are different depending on who accredits you. So within a hospital or a healthcare system, we have the Joint Commission, the Healthcare Facilities Accreditation Program, or HFAP, DNV GL Healthcare accredits, and then the new player on the block is the Center for Improvement in Healthcare Quality. Each of them have some similar requirements because they have to cover everything that is in the CMS regulations, but they also have their own spin on things. So just because a healthcare institution is a hospital doesn't, each hospital might have different requirements, and some of that might stem from what their accrediting agency requires. In a health plan or a payer, most of them are accredited by the NCQA, the National Committee for Quality Assurance, but URAC does do some of those too. And they also have pretty similar requirements, but there are some variations. So you might be asked for different things depending on which accreditor accredits the health plan that you're trying to get involved in. All the regulatory requirements are online as far as the CMS regs. There's some for hospital, there's some for managed care if you want to have a Medicare Advantage program. So they are out there, and anybody can download those and have access to them. You can have access to the same type of survey guidance that these are the actual documents that the surveyors get for providing guidance. So you can look at that and see what the requirements are. And within states, they vary by state. Some states have very complex hospital accreditation regulations. Some states have regulations upon saying who can be a member of the medical staff, so they may not allow genetic counselors to be a member of the medical staff. Some states just say that you have to be a doctor or a dentist or a podiatrist. Some states allow all different kinds. They just let the medical staff and the governing body determine who they want to be on staff. So it just varies by state. Some states just say, well, we follow the CMS and adopt the CMS conditions of participation. And so if that's the case, then the CMS just pretty much says that hospitals, governing bodies can just determine who they want to be on the staff. So it's wide open in that case. Credentialing and privileging are two separate processes, but they overlap somewhat. So the credentialing itself involves, just like it says, verification of credentials. So when we talk about credentialing, we're talking about verifying that you attended medical school or medical training, that you did a training program, that you have a certification, that you are licensed, and so those things, verifying those things is the credentialing piece of it, which is what you typically see in a health plan. But when you're getting credentialed in a hospital, there's another piece of it that's involved. It's called privileging. So privileging involves how that facility documents what types of procedures are going to be able to be done there, and how we're going to evaluate those procedures, to what exact treatment care services are going to be provided, and what are the qualifications for being able to request those privileges. So then the information that is collected during the credentialing process is used in the privileging process. So they are separate issues, and hospitals can sometimes allow people to have membership or appointment without having clinical privileges. Then there are some hospitals that have a separate staff category for non-physician providers. They may call them ancillary staff or allied health professionals, and so they may have a different category for people who are not physicians. So in privileges and appointment, in the healthcare institution, the facility decides who can be on the medical staff and who can be granted clinical privileges. But you have to be in compliance with state regulations. So if the state regulations say only physicians, dentists, podiatrists can be on staff, then those people are the only people who can actually be a medical staff member. But like I said earlier, they may put people who are non-physician providers into a different category and call them ancillary or professional staff or something like that. So you have to comply with your state regulations. Then there are licensed independent practitioners are those people who can provide independent treatment and care, and those people are typically credentialed through a medical staff process. Now, the people who are not providing independent care in many institutions are credentialed through the Human Resources Department, but that's not always the case. Some hospitals will say, well, gee, if we are not an employee, we're not going to credential you through the HR department. So they will say that even if you're not a licensed independent practitioner and you're not an employee or a contracted provider of the hospital, then you have to go through the medical staff office. So you just have to figure out where you fit in that at that hospital medical staff where you're wanting to apply. And it may be different in different places. But typically in a healthcare institution, in a hospital, we have medical staff bylaws, and those bylaws will define where practitioners who are non-physicians or non-licensed independent practitioners are credentialed. Within a health plan or a payer, the contracted and credentialed providers are defined by the organization. They get to decide who they want to credential and allow to be part of their provider panel. You have to be credentialed if you're an independently contracted provider. So if you're billing ancillary to someone, a physician is billing for your services, then you probably will not have to be credentialed by the health plan. But if you are independently contracted with them and billing, then you will have to be credentialed by that health plan. And the difference, health plans just credential. Healthcare institutions, hospitals, they will actually do the privileging piece of it. So what are some of the benefits to becoming credentialed privileged, and what kind of responsibilities do credentialed and privileged providers have to have? And so we're going to take a look at that, because there's some risks, there's some benefits to it, and there's some things that are maybe not so great about being an independently credentialed provider. So one of the things that we need to keep in mind is there is some new legislation that is pending right now before Congress. So at the time that we're conducting this webinar, CMS doesn't recognize genetic counselors as healthcare providers, and genetic counseling for Medicare patients can only be provided under direct supervision of a physician, and only to patients that are established patients of that physician's practice. But that might be changing, because H.R. 3235, which is entitled the Access to Genetic Counselor Services Act of 2019, was introduced in Congress in June of this year, in 2019. So this act allows for CMS to recognize certified genetic counselors as healthcare providers and to reimburse them for their services when they're counseling Medicare beneficiaries, in the same way that those services are covered when provided by a physician. That is currently pending before Congress, so we'll have to wait and see what happens with that. Working as an independent provider versus a healthcare institution employee or a physician employee, there are some benefits. If you're working independently, you can independently bill for services. Depending on your how much volume you have, you may actually make more money than in an employment agreement. You can set your own schedule. You get to be the boss. There's more flexibility, and you might have a better work-life balance. But also when you're independent, there are some other things to keep in mind too. You may have to hire your own staff and cover your own medical malpractice insurance. So there's and your workflow may not be as robust as if you're working as an employee. So you have to be able to carefully weigh those and evaluate whether or not you want to work as an independent provider versus an employee. If you're an independent provider, you will always have to be credentialed at health plans. And if you work in a hospital, whether or not you are an employee of that hospital or employee of a physician group, if you are going to, or if you're working independently, any of those situations, you will have to be credentialed by that organization and privileged if you're going to be providing independent medical and treatment decisions. Now, some health plans do allow, at the current time, allow for licensed genetic counselors to bill separately for services. So, but again, all health plans are different, and that has to be evaluated on a case-by-case basis. So there are some additional responsibilities if you're working independently. You have to maintain, if you're going to be credentialed at an organization, you have to make sure you're maintaining all those credentialing documents, that you keep everything up to date. There's you have to enroll, and with health plans, and you have to have appointment applications at hospitals and any place else that has a medical staff. So you will have to do that. That's maybe some extra paperwork that has to be done. Medical staff appointment and privileges might also add additional responsibilities. There may be a requirement for participating in quality assessment, performance improvement activities, and peer review activities within that medical staff function. There also are professional liability insurance requirements, and each medical staff is different. They all set different requirements in their bylaws and policies and procedures. So there may be additional responsibilities that you have as an independent provider within that healthcare facility. So working with credentialing experts at your health plan or payer, there's some things that you can do to kind of help make your job a little bit easier, especially if you're trying to figure out do you allow genetic counselors to work independently, or what's your process for it. So the provider relations department is usually the best first call to make, and they may end up forwarding you to somebody else. But calling the provider relations department and ask them, do they currently credential genetic counselors? And if the answer is no, say, who can we discuss this? Who can I discuss this with? So we can add this category of provider to the services. And again, who you talk to who you discuss it with is going to vary by payer or health plan. Another option is to look at the provider panel that currently exists for that health plan and see if there's someone with whom you can establish a relationship, maybe somebody who works in the same field that you do, and see if you can approach that person and ask them about establishing some kind of a relationship with them. If the answer is yes, then, of course, what do I have to do to apply for this? And then working with credentialing experts at a healthcare institution such as a hospital or a health system. Usually the best place to call is a medical staff office. And the medical staff office can tell you whether or not they are currently credentialing genetic counselors. And if they say yes, ask them, what do I have to do to apply for appointment and privileges? And also find out, are they credentialing genetic counselors as independent or dependent? If the state law allows them to function, allows genetic counselors to function independently, then it could be that the hospital also allows that. But that is not always the case, because remember I said earlier that the hospitals get to decide who wants to be on the medical staff. So even though the state might say that you can function independently, the hospital might have some kind of a requirement for a sponsor or a physician that would be someone that you would have to work with. So ask them if they're independent, if you can be credentialed as independent, or if it's dependent, and if that physician sponsor is needed. And if a physician sponsor is needed, then find out who, get a listing, go to their website and find out who's on staff in your specialty and that, where you want to provide, the area you want to provide services, and see if there's somebody that you can establish a relationship like that with. If they tell you, no, we don't currently credential genetic counselors, ask who you can discuss that option of adding that category of provider to their services that are already being provided there. Get the name of the medical staff president, department chairperson for your specialty. And some hospitals have departments, some do not. If they're departments, if they're departmentalized, if it's a big enough hospital, they're probably split in different departments. So ask about the name of that department chairperson or the name of the medical staff president. Talk to them. Send them a letter asking them if you can talk to them about adding genetic counseling as a category to the medical staff or the allied health staff, depending on how it's worded in that specific medical staff bylaws. And don't take no from the medical staff coordinator. So the medical staff coordinator at the hospital is a person who's typically responsible for doing all the credentialing. And if that person just says, no, we just don't have these people, don't just take no for an answer. Go ahead, ask them, who can we discuss this with? Who is the best person for me to bring this to their attention? and follow up with that. Don't just take no for an answer. So you can also, another thing that you can do within a healthcare system is write to the medical staff president with a formal request, not just a, letter saying, hey, can we chat? I'd like to be able to talk to you about this. Do a formal request. Do a formal request saying that you would like the medical staff and the hospital to consider adding genetic counselors, and then carbon copy that letter to the chairman of the governing body. You can get that name from administration. That way, if you write it to the hospital and the governing body, or you can write it to the governing body in care of the chairman of the governing body. That way, it's something that would get on the governing body agenda, possibly, and be able to have a formal, process for somebody taking a look at it, rather than just having the issue of somebody saying no or whatever. Also, directly contact those physicians whose patients can benefit from your services and ask them to help or to provide sponsorship, and get their backup on this. So that way, when you write to the medical staff president and the governing body, you can say, I have the support of these physicians, and maybe even get a letter of support from them to ask them to support your wanting to get onto the medical staff there. And then follow up. If you don't hear something back right away from someone, or within 30 days, if you don't hear something back, follow up with it. Don't just let it fall by the wayside. Sometimes hospital boards and medical staffs don't meet right away. You may have a board that only meets once a month or every other month, and so it may take a while for this to work its way through the official process. But so follow up with a phone call to the person you wrote to, if you don't hear something back within a month, and see if they're, what's going on with your request. If it's sitting there, not doing anything, or if it's actually going through a process and moving through the process. Okay, let's switch gears a little bit here, and let's talk about the actual processes for credentialing and privileging, so we can see what are you going to have to go through when you want to apply for privileges somewhere. So a complete application has to be filled out, and a complete application is one that all the blanks are filled out, all those questions answered. Any kind of required attachments that are part of that application have to be included there, and there have to be signatures on attestations and consent and release forms. All of those things have to be there before that application will ever advance to the very first level of review. Within a healthcare institution, there's typically verifications of credentials like licensure, the DEA, education, training, certifications. There's a requirement for professional references. Typically it has to be somebody that's in the same specialty as you are, so it would have to be another genetic counselor would be required to provide those professional references. And then we have the privileging piece of it. So part of privileging, they verify the applicant's character, judgment, competency, experience. So you may be asked to provide information about the types of patients you've seen, other places where you've worked, numbers of patients that you've worked with. And the character and judgment will probably be evaluated through the professional references that are received. Within a health plan, they just credential. They don't grant privileges. So they're just verifying those credentials, your license, education, training, certification, work history, sanctions, malpractice history. Work history is something that is covered under the experience in a healthcare institution. And hospitals will verify work history. They will write to the other places where you have worked to confirm that employment, or if you've worked as an independent practitioner, then they will ask the medical staff office to provide that reference, that verification. With it at a health plan, the work history, you just have to provide a listing of your work history, usually going back 5 years, or some go back 10. Typical review and approval processes within a hospital. The first step is you have a credentialing expert who does the verification of credentials, checks all those things that we talked about on the previous slide. And then we have, if it's a departmentalized medical staff, there will be a chairperson for that department, or it may be divided into services. So the department chair or service chief would review your application, all of those verifications that came back, and make a recommendation. Now, at that point, the department chair might say, I want to get some more information. So if that's the case, there may be a follow-up letter to you or to one of the references that they've received back to try to get more information. After that recommendation is made, it goes to the Credentials Committee if they have such a thing. Some hospitals have Credentials Committee, some do not. Some might just refer everything to the Medical Executive Committee. So the Medical Executive Committee will then review the information received, including the department chair's recommendation, and then it will make a recommendation to the governing body. The medical staff doesn't approve anything. All the medical staff does is make recommendations. The governing body is the final review and the final decision. So you can see that these steps take a little while, so it takes some time to get this done. Within a health plan, things move a little bit quicker. They verify those credentials, and because they don't do the privileging piece of it, it may go a little quicker. And then some health plans will have a medical director review and recommendation, and that will serve as the final decision. So the medical director typically does a review. Sometimes they may review the whole file depending on what kind of information is received, if there's any problems with the application, or they may just look at a list of providers and make that recommendation based upon looking at a list. And in some places, this medical director review will be the final decision. In cases where there may be a problem with the credentials file or a question about anything, it may go to a full Credentials Committee review and recommendation. There's not a requirement that health plans do let the medical director sign off for the Credentials Committee, but that is an option that they can have under their NCQA requirement. So if some managed care plans will have a medical director review and recommendation and that serve as a final decision, some will make all files go to the Credentials Committee. So it just varies depending on how that health plan has set up its review process. So how long does this take? Well, it depends. Within a hospital medical staff or a health plan, the staffing, how many people do we have doing this job? Are we using a credentials verification? Are we delegating any of our credentialing to someone else? That might take a while. And how long does it take to get the information? In a hospital, we have to have that documentation of competency for privileges, and so that requires us writing to other facilities and getting peer recommendations. How long does that approval process take? If there's monthly meetings or they have an expedited process, it might move through a lot quicker. And depending on if everything has to go from one meeting to the next, it's going to depend on the meeting schedule. Even if you have a complete file, if it doesn't get completed until the day after the Credentials Committee, you're going to have to wait till the next Credentials Committee to get that through. Within a health plan, again, the staffing it takes in whether or not there's a delegated agreement for credentialing. It might make things go quicker or slower. So you really don't know how long it's going to take the information if you're writing to other people and getting things back. Sometimes it takes a while to get that information back. The Credentials Committee meeting schedule and whether or not they have that medical director sign-off option for those clean files. And then if things are slow, the health plans have requirements that they have to meet for their accreditor, that documents have to be verified within a certain time frame. And if something is taking a long time to get back, they may have to go back and re-verify some outdated verifications. So all of this is going to depend, pretty much the number one thing it's going to depend on is the staffing. How many people are working there, and how much work do they have to do is the big thing that slows things down. Okay, so appointment periods are also in effect for the various accreditors. So for Joint Commission, HVAP, CIQH, those are ones that accredit hospitals. You can't go over 2 years. So every 2 years you have to do this again. So you fill out an application one time, 2 years later you're filling out another application. With health plans, you have to credential at least every 36 months. So that, and within a health plan, they've got a little bit of wiggle room. That 36-month cycle is counted to the month, not the day. So for example, if you're credentialed on July 8th, 2019, you won't have to be re-credentialed there until July 31st, 3 years later, 2022. DNV is with another hospital accreditor, and they require, even though their regulation, their requirements say every 3 years. So, but if the state law says that you have to re-credential every 2 years, then you have to follow what the state law requires. So even though it is, DNV might say 3 years, it's still going to end up that you might have to be re-credentialed every 2 years. All right, so that was the end of my section, and I'd like to turn things over to Cheryl, who's going to talk about credentialing in states without licensure.
So thank you, Kathy, for such a detailed description of this very complicated process. I have been asked to talk about what my experience was in payer credentialing when I was providing genetic counseling in a pediatric clinic. I do have a conflict of interest to disclose. I am an employee of Quest Diagnostics. However, what I'm going to be talking about is completely related to the clinical care I was providing in my prior employment. So to set the stage of the landscape that I was working in, so I worked for a large suburban academic medical center in metropolitan Detroit. I was a sole genetic counselor in a pediatric and general genetics clinic and working with one clinical geneticist. Michigan did not have licensure at this time, and we're talking about the time frame of 2014. However, it was also a time when some of the payers in the area were starting to accept the CGCs as billable providers within their systems. Notably, Priority Health was in Michigan and was starting to become a bigger a payer in our area, and they did accept certified genetic counselors in their systems for billing. Also, in our facility for a few years, the prenatal genetic counselors had been billing with the 96040 code, but they were billing under a facility fee, and that it will become relevant a little bit later in the presentation here. So we worked in a pretty traditional model up until that time, where I would go in and get the history, followed by the exam by the physician, and just discussions of findings and recommendations. The bill that was generated was a physician bill as an evaluation and a management code, and there was no independent billing for genetic counseling. My position at the time was also funded by a philanthropic source, so there was no expectation that this position was going to generate revenue. So what was changing at this time, though, was that the source for my position was going to be changing from the philanthropic source to a physician group. So we were approached by the head of our department that we needed to create a billing revenue service for my position, because there was going to be an expectation now to generate some revenue independently from my service. So we assembled a team, and I had to say I was very fortunate that the department chair was able to help put together with us who needed to be involved. And over a 2-month period, we decided that the way we would do this was unpair the gen counseling portion of the visit with the physician visit. We would bill separately for my portion and use the 96040 code, and that it would be billed as a professional fee and not as a facility fee. The reason for that being is that if billed as a facility fee, the revenue that was generated would go back to the hospital and not to this physician group. And because the revenue had to go to the physician group to be recognized, it needed to be a professional fee. In order to do that, I needed to be credentialed with the payers that were contracted with the hospital and be accepted as a provider within each of those systems. So how did we get started here? Well, we had to do some due diligence, finding out what the payer mix was for our area and what their policies were for covering gen X services provided by gen counselors. I knew a little bit about that, but I didn't know the percentages, and that we needed to have the people that in the hospital that could provide us with that information, participate in these meetings. Also identifying an administrator, a champion for this. And I have to say that the chief of our department was really the person that really steamrolled this. He was very much in support. And without that, I don't think this would have happened. And also developing the contacts within the credentialing area was very important to get the ball moving here. So we needed to collect data and metrics. This part of it wasn't that difficult for us because we only had one gen counselor and one physician. But for those of you who work in a bigger clinic with multiple gen counselors and multiple physicians, exactly how many patients we're talking about for each provider, how many billable providers are going to be affected. And then because we were changing how we saw patients, what was the impact on scheduling, on clinic space that's so important these days? What was going to be the expected impact on our billing department? And this was an area that I didn't appreciate before starting, and I'll talk about this a little bit more in a minute. And then what we were going to charge, and that became irrelevant because it needed to be high enough that it would justify what the charge was going to be, what we get back in revenue, and the time spent on the billing and the process at the end to justify moving forward. So did I encounter some roadblocks? Absolutely, and very relevant to what Kathy just discussed. We did get some pushback about what the payer coverage policies were. I had to go and pull those online from each payer to show, and we actually had a big spreadsheet of who would and who would not accept me as a provider or cover these services. We found that there were probably 3 or 4 plans in our area that would accept it, and they had high enough percentages in our payer mix that made moving forward relevant. Again, the impact on billing, the time amount to submit claims, to review claims when they came in, process denials, collect information that was needed to get back. I didn't appreciate exactly how that impacted the decision to move forward or not. And then the estimated revenue that we would get. I also didn't appreciate the impact the physicians would have on this. Obviously, we were changing how we saw patients, so it changed their workflow, it changed their schedule. We had to compete for clinic space. And then the decrease in physician billable hours. And again, this depends on how you're already seeing patients. If you're seeing patients and physicians have to come in at the end to discuss the findings and to finish up because of billing, if they're not doing that anymore, they have a decrease in the amount of time they can bill for the time that you both have spent. So maybe freeing up their time and not seeing patients with you can help offset that if they can put in other patients at that time that they can bill for, but they can push back on this. I was fortunate that the physician that I worked with was very much on board with all these changes, felt that it was all in a positive light, and we were able to move forward. So the keys to being successful in this area, eventually getting credentialed with the few payers that would allow it, was really having an administrator support and the physician support. And I can't tell you what a difference that made. And had we not had those two pieces, I'm sure I would not have been successful in this area. The support of data was also critical. If we found that payers in the area were just not going to be willing to credential me, I'm sure it would have fallen off. Two of the biggest payers in the area, Blue Cross Blue Shield of Michigan and Michigan Medicaid, did not allow me to be credentialed, so we were not able to bill for those. And then to keep the momentum going, again, to reinforce what Kathy had said, is that at any point along the way, this can fall off their radar, all the people that have to be involved, and it's easy to do that. And I had to be the one to keep the momentum going to move it forward. Just like so many other areas that we run into that are not familiar with genetic counselors, there's a lot of education about who we are and what we do and how we do it to get all of these individuals on board that really have to be on board. In particular, the managers, the credentialing contacts, and the billing folks are the people that really didn't understand why we were moving forward. So, and it took a lot of time to educate them on who we are, how we're educated, and what we do. And the team is likely to be the same folks that are on this list, but there could be others depending on your institution. Once you have a plan, my recommendation would be to stick with it. It may have to be tweaked here and there as you go through this process, but again, keep the momentum going. And last, fingers crossed and hope the stars align to be successful here. So, and with that, I'm going to end and turn this back over to Samantha for some final comments and resources. Thank you so much.
Great. Thank you so much, Cheryl, and thank you so much to Kathy for incredible presentations and learning more about credentialing and what this could mean for our membership. So for those looking for additional resources, resources on credentialing can be found on the NSGC website. The Vice Chair of the Service Delivery Subcommittee, Emily Booth, and I recently wrote an article that will be appearing in the first quarter issue of Perspectives for 2020, entitled Credentialing, a Committee's Adventures Through Learning About and Learning to Love Credentialing. We've also created what, why, and how documents on credentialing. So in case you're looking for one-page documents on what credentialing is, as Kathy has described so well, why credentialing is important and how to go about it, as Cheryl has pointed on, but knowing that this experience could be different for various genetic counselors given the setting. Those documents are there, as well as an FAQ document, all intended as supplemental materials to this presentation. These can be found on the Tools for Your Practice page. We'll be hosting a more in-depth online course on credentialing in spring 2020, so keep an eye out for more information on that. If you have any additional questions about credentialing, please email payer@nsgc.org. Thank you to our speakers and to you for taking the time to learn about credentialing, and we hope you'll check out all of the resources NSGC has to offer on this subject. Thanks so much.